The protein synthesis inhibitors. In this group, we will discuss the aminoglycosides, the tetracyclines, chloramphenicol, clindamycin, macrolides, and linezolid. We divide the protein synthesis inhibitors according to their target, either the small subunit, which is the 30S, or the large subunit, which is the 50S. The way to remember them is the phrase "by at 30". So aminoglycosides and tetracyclines inhibit the 30S subunit, and the rest inhibit the 50. Let's review the steps of protein synthesis to know the target of each of these medications. The first step is that the different structures will come together to form the initiation complex, and this is what we call initiation. The second step is that the tRNA will come and bind, and then we will form a peptidyl bond between the amino groups, and this is what by the enzyme peptidyl transferase, and lastly the ribosome will move to carry on with the protein synthesis. The first step, or the initiation, is targeted by linezolid. So linezolid affects the launching or the initiation. Also by aminoglycosides. A is the first letter of the alphabet, so it affects the first step or the initiation. Then the binding of the tRNA is inhibited by the tetracyclines. So the T goes with the T. Then next, the peptidyl transferase and the formation of the peptidyl bond is targeted by chloramphenicol. It's the only one that has a P, so it affects the peptidyl bond. Also, chloramphenicol affects the formation of the peptidyl bond. Lastly, the movement of the ribosome is affected by the macrolides, so macro affects the movement. Also, the last one is clindamycin, so clinda clings to the ribosome, preventing the movement. The mechanisms of resistance are also easy. The aminoglycoside starts with an A, so acetylation and adelination or phosphorylation. Tetracyclines with a T, so transport pumps, which pumps the drug out of the bacteria. Macrolides with an M, so methylation of the ribosomal RNA. Linezolid, mutations in the RNA. Chloramphenicol, the bacteria transfer and acetyl groups deactivating chloramphenicol via the enzyme acetyltransferase. Now we'll go through them one by one. Let's start with the aminoglycosides. These end in mycin, so gentamicin, neomycin, tobramycin, streptomycin, and amikacin. The rule is just to say no to aminoglycosides. So no protein synthesis, no bacterial growth, so it's bactericidal. The spectrum is gram-negative organisms. There's another use, which is we use neomycin for bowel surgery. It decreases the colonic bacteria, preventing further dissemination during the surgery. The aminoglycosides need oxygen for them to work, so they are ineffective against anaerobes. The side effects are neuromuscular, and ototoxicity, so they can worsen myasthenia gravis due to their neuromuscular effects. And there is no use in pregnancy since they are ototoxic. Next, we have the tetracyclines, which are doxycycline and minocycline. Tetracyclines shouldn't be taken with antacids since it chelates them and inhibits their absorption, same as we will discuss in fluoroquinolones. The clinical use is with ticks, like Lyme disease or rickettsia. So TITS for ticks. And we have another drug, which is the tigacycline, which is a tetracycline derivative. But this drug has a broad spectrum of coverage, and it covers the multi-drug resistant organisms like MRSA and VRE. The side effects of tetracyclines: in children, it affects the teeth and bone growth. In adults, it causes photosensitivity. Moving to chloramphenicol. Now it's limited in use because it's very toxic, but still it's used in the developing countries since it has a low cost. The side effects: anemia, which is dose dependent. So as the dose increases, there is more bone marrow suppression and more anemia. The second side effect we cannot predict with the dose, so it's dose independent, which is aplastic anemia. Lastly, gray baby syndrome in premature infants. The babies, they have very low conjugation enzymes in their livers, and this leads to increased levels of toxic metabolites of chloramphenicol. The baby will be pale, and on top of that will be cyanosed, so the end result is a gray color, and this is gray baby syndrome. Moving to clindamycin, we use clindamycin for anaerobic infections above the diaphragm like aspiration pneumonia or lung abscesses or oral infections. So the rule is anaerobic infections above the diaphragm we use clindamycin, below the diaphragm we use metronidazole. The important side effect is pseudomembranous colitis by C. difficile. Clindamycin eradicates the normal microbiota and C. difficile outgrows and causes pseudomembranous colitis. This is an opportunity to review the antibiotics that cause pseudomembranous colitis, which are ampicillin, fluoroquinolones, clindamycin, and cephalosporins. Macrolides, which are azithromycin, clarithromycin, and erythromycin. We use them against atypical pneumonia like Mycoplasma, Chlamydia, or Legionella. We use azithromycin in sexually transmitted chlamydia, and we use macrolides in MAC, which is Mycobacterium avium complex, so MAC for MAC. The side effects can be remembered using the mnemonic macrolides. So the M is for motility issues in the GI, A for arrhythmia, they prolong the QT, C for cholestatic hepatitis, R and O for rash and eosinophilia. Another use for macrolides is that we give the babies erythromycin ointment to prevent gonococcal conjunctivitis. Also, macrolides can lead to infantile hypertrophic pyloric stenosis, since they cause motility issues of the GI of the young infants, and this can lead to pyloric stenosis. Linezolid, we use it for gram-positive organisms, also for resistant organisms like MRSA and VRE. The side effects are thrombocytopenia and serotonin syndrome, since it inhibits the MAO enzyme. Streptogramins, which are quaniprestin and dafloprestin, they have the same indications as linezolid,